Good evening, everyone present here. I am Faraz from IGCP Group. Welcome all the participants on today's webinar. Let's welcome today's speaker with great honor, none other than Dr. Ramesh M. Bhatt, sir. And let me share some of the achievement of sir. Sir is a skin specialist, professor at the Department of Dermatology at Father Muller Medical College, and head of research, Father Muller Research Center, Bangalore, Karnataka. And today he is going to speak on a very important topic on the occasion of World Psoriasis Day. And the topic for today's discussion is overview of psoriasis and its management. To know more about this topic, I would like to invite sir and hand over this session to sir. Over to you, sir. Stage is yours. You can proceed from here.
Thank you. Let me thank IJCP for giving me this opportunity. Good evening to all colleagues all over India. So I'll be basically talking about psoriasis and overview and its management. In fact, today we observe World Psoriasis Day all over the world. October 29th, we observe Psoriasis Day. And we have the theme today, psoriatic disease and the family, from awareness to action. Because if somebody suffers from psoriasis, it is not just the patient who suffers from psoriasis, but it is a full family. So the family has to be behind with this patient. And many a times the disease gets exacerbated when there is no psychological support. So the support from the family is important, and that is a theme that we have selected this year. Remember, at any given time, 60 million people in this world are suffering from psoriasis. One type of psoriasis or the other. It may be mild, moderate, or severe. It's one of the common chronic inflammatory and proliferative condition of the skin in which both genetic and environmental influences have a crucial role. It is basically, even though we call it as a skin disease, it is more in like a metabolic disease. Patients with psoriasis many a times will have other comorbidities also. It presents with red, scaly, sharply demarcated, indurated plaques, and a classical description is that it is mainly seen on the extensor aspects of the body. Of course, there is a variant called as flexural psoriasis. So, as I've already told, nearly 60 million people are suffering from this disease all over the world. The age of onset, there are actually two ages of onset. One is in the early life, and another one is in the middle or late life. So, early onset will be the more severe diseases and more likely to have an affected first degree relative. Whether if you ask whether it is a genetic disease, partially yes, partially no. It is not just the genetic component is responsible for the disease. There are other environmental triggers also. Even though in India we tell that males gets affected more than women, the sex ratio is almost equal. So both males as well as females get affected by this chronic papillosquamous disorder. Coming to the etiopathogenesis, as I have told, there is some genetic predisposition, and if you ask the HLA studies, then we have HLA B13, B17, both in India quite common, and in other parts of the world HLA BW16. So it is the genetic predisposition plus environmental factors probably trigger the occurrence of psoriasis. What about the triggering factors? Trauma is very important because in a patient who has got active psoriasis, even scratching can result in increase in the number and intensity of psoriasis. Sunlight, sometimes it is beneficial, but during the active stage of the disease, exposure to sunlight may actually increase the severity of psoriasis. There are various systemic factors also. Bacterial infections, viral infections can precipitate psoriasis. Stress, probably one of the most important aspect as far as psoriasis is concerned, because nowadays we are seeing increasing number, probably because of this stress. Various drugs also can precipitate psoriasis. Coming to the seasonal variation, we always see that psoriasis is more severe during winter. Then, as I have told, it is more considered now as a metabolic syndrome. Patients with psoriasis many a times are obese and they may have other comorbid conditions like diabetes and cardiac problems. Alcohol, of course, increases the severity of psoriasis. So it is environmental factors, that is infections, drugs, alcohol, smoking, psychological stress, and the genetic factors. There is activation of antigen presenting cells, which result in activation and proliferation of the T cells, which release various types of cytokines, the interleukins, which are responsible for proliferation of keratinocytes. In fact, the normal turnover time in a normal skin is around 50 to 72 days. But whereas in psoriasis, it is reduced by 7 times. So sometimes the turnover takes hardly 5 to 7 days. There is fast turnover of keratinocytes. That is the reason why a proper keratinocyte is not formed, because of this rapid turnover. And usually there will be resting cells in normal human body, resting cutaneous cells or the keratinocytes. These also become active in psoriasis because of the influence of the various cytokines. So there is profound proliferation, and that is the reason for the scaling what you see in psoriasis. Triggering factors, as we have told, trauma, say Kibner phenomenon. Kibner was a dermatologist from Poland. Recently, I had the opportunity to visit the university where he was working. So this Kibner phenomena indicates that new lesions of psoriasis occur along the line of trauma. It may be scratching, it may be a surgical incision, or it may be an accidental trauma. So this trauma may be physical, chemical, thermal, electrical, mechanical, and allergic. The trauma need not result in injury to the skin. There may not be an obvious raw surface in the skin. Even a pressure can induce this Kibner phenomenon. As I already told, seasonal variation, there is worsening during winter, and increased humidity is beneficial. Sunlight, sometimes it is beneficial and sometimes it is worsens the disease. It worsens the disease, especially when the disease is very active. When we see Kubner's phenomenon, when the lesions are red, so these are the patients who develop exacerbation of the disease because of the sunlight. Then infections, especially in children. Previously, an episode of streptococcal sore throat used to precipitate a type of psoriasis called as guttate psoriasis. Guttate means raindrop like small lesion with scaling. So many a times you treat the streptococcal infection and the psoriasis used to subside. So they are more prone to develop psoriasis in future, these type of individuals. So infection, some of the viral infection can exacerbate psoriasis or even precipitate psoriasis. We used to see lots of cases of exacerbated psoriasis in patients who had COVID also. Then drugs like NSAIDs, beta blockers, antipsychotics like lithium, rapid withdrawal of corticosteroids, quinine, anti-epileptics all can increase the severity of psoriasis. NSAIDs, we know that it inhibits the cyclooxygenase pathway, but there is no inhibition of the lipooxygenase pathway. So there is diversion towards the secretion of leukotrienes, which are highly inflammatory. That is the reason why psoriasis increases. Beta blockers, which decreases the production of cyclic AMP and thus exacerbates psoriasis. Lithium enhances the chemotaxis of neutrophils. That's why it enhances psoriasis. Rapid withdrawal of corticosteroids. You see, psoriasis is the one disease where we have to remember that giving oral steroids or injectable steroids is not good. Momentarily, there may be cessation of erythema. Momentarily, there may be cessation of the scaling. But the moment you withdraw corticosteroids, there will be sudden flare. This has to be borne in mind. Sometimes patients with psoriasis will go for pustular psoriasis. Only in life threatening conditions you can give, just to overcome the crisis, you can give corticosteroids. Otherwise, corticosteroids are contraindicated in the management of psoriasis. So, what are the various clinical types? The most important and the most doctors see is chronic plaque psoriasis, where you see erythematous scaly plaques distributed mainly on the extensor aspect of the body. Scalp may be involved. The gutted psoriasis, as I've already told, common in children. It is usually post-infectious. Maybe as the streptococcal infection has comparatively come down, nowadays we don't see too many cases of gutted psoriasis. This was not the same case 25, 30 years ago. We used to see quite a good number of gutted psoriasis cases, and we used to be happy also to treat, because we give a course of anti-streptococcal antibiotics. Then the gutted psoriasis is to resolve. When there is involvement of more than 85 to 90% of the body surface area with these scaly erythematous lesions, we call it as exfoliative psoriasis. Then we have got pustular psoriasis, where you see sterile pustules. It is not because of any bacteria, it is not because of any viruses, it is just a collection of neutrophils. Neutrophils are chemotactically attracted towards the epidermis and they form pustules. So the one which is generalized variety is called as von Jumbusch type, and there is a type known as exanthematic type, annular type, localized type of generalized pustular psoriasis. There may be even just palmoplantar pustular psoriasis also. We call it as Barber's disease. In fact, nowadays the von Jumbusch type or the acute generalized pustular psoriasis is considered a different pathogenetic mechanism where interleukin 36 is involved, and today we have a biologic which specifically acts on this interleukin 36 called as pesolimab. It is quite costly, and currently it is available in various parts of the world, including India. Then what about how to make a diagnosis? Diagnosis is quite easy, and um, there is usually no differential diagnosis. But in case if you got any doubt whether it is psoriasis form, especially when it is drug induced, when you have got doubt whether it is eczema or psoriasis, in the eczema there will be oozing, whereas in psoriasis oozing is usually not seen. Oozing occurs only if there is any application of irritants. Otherwise, this eczema, it can be easily distinguished from eczema. Then lichen planus, there will be severe itching and violaceous hue will be there. It is another papillosquamous disease. The one with which we usually confuse is there is a condition called as pityriasis rubra pilaris. So that is the time when we do this histopathological examination. And what we see in histopathology, you see the from above downwards, that is the stratum corneum is the topmost layer. There we see nucleus, nucleated cells. Normally in the stratum corneum we don't see any nucleus. So the nucleus is retained because there is a rapid turnover of the cells. There is no time for keratinization of the keratinocytes. So the nucleus is retained. That is called as parakeratosis. And many a times there will be hyperparakeratosis. But the problem when we are doing biopsy, the scales are very loose. It doesn't get attached to the tissue. So there may not be stratum corneum at all. So the hyperparakeratosis is a classical picture, but sometimes there may be even absent stratum corneum because we would have lost it while rubbing the skin, or if there is scratching, patient might have removed that scale. So these are the possibilities. Then in the horny layer, there may be collection of neutrophils. And if the collection is quite large, it results in pustular psoriasis. This is called as Munro microabscess. And these are all sterile pustules, not because of streptococci, staphylococci, pseudomonas, or other bacterial conditions. Okay, there is only collection of neutrophils, sterile pustules, what you see, and there is absence of granular layer because there is no time for the granular layer to have these keratohyalin granules. There is absence of granular layer. Elongation of the reader ridges, you call it as camel foot appearance or club shaped reader ridges. Then there will be elongation of the dermal papilla, finger like projection of this dermal papillae, and above that there is thinning of the suprapapillary part of stratum malpighiae with occasional spongiform pustules. I will show you in the photographs of histopathology. Then there may be nail psoriasis, mucous membrane psoriasis, psoriatic arthritis. Then there will be regional variations, only involvement of the scalp, facial involvement, inverse psoriasis or body flexural involvement, only involvement of the palms and soles. All these can occur in psoriasis. Psoriasis is a disease with wide range of manifestations, and this is a classical histopathological picture what you see here. Here there is hyperkeratosis. Of course, here the scales are quite adherent. Most of the time you don't get this picture. The scales would have been flown away from this other parts of the epidermis, and there is absent granular layer or very thinned out granular layer, and there is elongation of the rete ridges or the club shaped or the camel foot type of rete ridges you can see here. And you can see the collection of the neutrophils here. Here you can see very well. You call this as Munro microapsis when it is present in the stratum corneum, and when it is present in the stratum spinosum, you call it as spongiform pustules of Koyo. And there is elongation of the dermal papillae, the finger-like projection that you can see, and there will be vasodilatation, dilated capillaries, proliferation of the capillaries, and the lymphocytes may be seen in the dermal papillae. There will be migration of these neutrophils from the dermal papilla upwards to the stratum spinosum and then to the corneal layer. That is the reason why you get these sterile pustules, sterile collection of neutrophils. It's a very classical example of collection of neutrophils. As I've already told, it is sterile. So, coming to the clinical features of psoriasis, what you see commonly is sharply demarcated plaques. Scales are loose, abundant, dry, and silvery white. Under the scale, skin has a glossy, homogeneous erythema. There is a specific sign to elicit psoriasis for the confirmation, the clinical confirmation of diagnosis of psoriasis. Removal of the thin suprapapillary epidermis by gentle scraping with a glass slide reveals vascular bleeding points. That is because there is suprapapillary thinning of the epidermis and there is vascular proliferation, vasodilatation. We call it a squirting papilla. Okay. So when you scrape, there will be bleeding, and pinpoint bleeding is called. The test is called as Grata test, and the sign is called as Auspit sign. So this is how it is being elicited. You remove the scale with the help of a glass slide and you can see the tiny bleeding points. This is called as Auspit sign. If you see Auspit sign, then it is an indication that the diagnosis is almost confirmed. Histopathology may not be required at all. So the chronic plaque psoriasis is the common type where you see coin-sized to palm-sized, well-defined erythematous squamous plaques, most of the time distributed bilaterally. Of course, it may be a localized type of psoriasis also sometimes. Extensor surface is commonly affected. That is quite characteristic for psoriasis. Of course, there is a flexural variant also. You see, lichen planus mainly we see lesions on the flexural aspects, whereas psoriasis is mainly seen on the extensor aspects. If there are coin-shaped lesions, then we call it as nummular psoriasis. If there are too many geographic type, then you call it as psoriasis geographica. When the adjacent lesion coalesce, they form larger lesions. Here we can see the examples of scaly plaques. So there is erythema at the periphery and very thick scales, silvery white scales. This silvery white is because the keratinization is not complete. There is no time for the keratin to be deposited inside the keratinocytes, and there is retention of the nucleus also, and the air gets trapped between the scales. That is the reason why it is silvery white. And when you scratch, there will be bleeding points. You call it as Auspit sign. These are well defined lesions you can see mainly on the extensor aspect here and even on the buttocks. Here you see the adjacent lesions have coalesced, so almost looks like Australia and New Zealand here in the reverse position. So geographic type of lesions, that's what you see in psoriasis. Gutted psoriasis, as I already told, most of the time post-streptococcal, seen in children commonly. Gutted, the meaning of gutted is raindrop-like. So pinhead to pea-sized erythematous papules which erupt abruptly after an episode of fever and sore throat, mainly over the tongue, and palms and soles are spared. And as I have told, give a good anti-streptococcal antibiotic, the usually the lesions disappear. Then this is what you see in gutted psoriasis. So raindrop like small lesions. The adjacent lesions coalesce to form larger lesions. And then exfoliative psoriasis, it is an emergency. You see, always many people ask, where is emergency in dermatology? This is one of the emergencies in dermatology. Exfoliative psoriasis, patients will be having chills and rigors, there will be tachycardia, a patient will be losing heat from the body. It may go to, the patient may go for hypothermia also, and all these lesions are erythema, scaling is there, erosions may be present, and it is a nidus for bacteria to grow, and the patient may even go for septicemia. This was an emergency. Psoriatic erythroderma, where there is more than 85 to 90% of body involvement. As I have told, the most common problem is giving steroids for psoriasis. So either it may be topical or sometimes even systemic, and all these, some of the native medicines also can precipitate psoriatic erythroderma. There will be increased heat loss. So a psoriatic erythroderma is not just a skin condition, it is a involvement of all the systems in the body. There will be dehydration, there will be concentration of the blood, tachycardia will be present, the patient may go for renal failure. So there will be pitting edema of the legs because of the hypoalbuminemia. Hyperpyrexia can occur. Then decreased sweating, and there will be loss of the nutrients from the body. Proteins are lost, iron is lost, vitamins are lost, and it can also result in hypocalcemia and hypoalbuminemia. There will be barrier function gets affected, and skin blood flow will increase, and cardiac output also will increase. So it results in tachycardia, and sometimes even for high output cardiac failure can also occur with psoriatic erythroderma in patients who have already got the cardiac problems. Here you can see the severe erythema and scaling involving the full body. Then pustular psoriasis, I will not talk much about this. As I have told, the currently we consider von Jumbush type of generalized pustular psoriasis as having a separate pathogenesis involving interleukin 36. Here what you see is, because of the collection of these neutrophils, no, there will be sterile pustules. When the neutrophils predominate in the skin lesions, it forms pustules, and we call it as generalized pustular psoriasis. Once again, von Jumbush type of generalized pustular psoriasis is an emergency. The patient may go for hypothermia, patient may go for high output cardiac failure. This pustular psoriasis may be localized also. There is a entity called as Barber's disease, where there is only involvement of the palms and soles. So here we can see the von Jumbush type of pustular psoriasis. If you take a smear from this, you see only neutrophils. There will not be any gram positive or gram negative organisms. So what, these are all sterile pustules. And nail, there may be involvement of nearly 20 to 50% of cases of psoriasis. The nail matrix involvement can result in pitting, crumbling, red lunula, and leukonychia. Nail bed involvement can result in subungual hyperkeratosis, vancolysis, that is detachment, the distal detachment, then Salmon patch or oil drop sign can be seen. And this is what you see, the nail pits. That is because of the parakeratosis, keratinocytes are being fallen off. So that is the reason pits are present. And here almost there is a complete nail dystrophy, and here you can see along with the nail dystrophy there will be involvement of the dorsum of the fingers. Many of these patients will have psoriatic arthritis also. So whenever the lesions are seen on the fingers, so you ask for a history of joint pain, because that is the one system that gets affected very commonly in psoriasis. And the psoriatic arthritis, the most important five types are: one is the classic psoriatic arthritis, where there will be involvement of distal interphalangeal joints. It is seen in 5% of the individuals. Rheumatoid arthritis, like where you see The involvement of the metacarpophalangeal joint, that is in 5%. Arthritis mutilans with the destruction of the bone, that is seen in 5%. Oligoarticular arthritis, that is the commonest, nearly 70%, involving either a one elbow or one knee, two knee, like that. Then arthritis mutilans, once again, very severe form of um, um, uh, this one, psoriatic arthritis. And there is ankylosing spondylitis, like, that is involving the axial skeleton, that also can occur. So these are the various, or we call it as psoriatic spondylitis. The oligoarticular arthritis is the most common. So scalp psoriasis, you can see the lesions on the scalp here, and the removal results in bleeding, and many a times we give coal tar shampoos for these patients. So require a very good shampooing, and if there is secondary infection, sometimes we may have to give a course of antibiotic in managing scalp psoriasis. This usually psoriasis is seen on the extensor surface. Does psoriasis involve flexural aspect? Yes, sometimes it can. And there is a variant called as flexural psoriasis. There is a variant called as sebo-psoriasis. Both will have more flexural involvement than uh, the extensor involvement. Coming to the treatment, so next 3 to 5 minutes, I will talk mainly about the topical as well as systemic treatment of steroids. Topical corticosteroids we can give if the lesions are localized. As I have told, better to avoid topical corticosteroids when the lesions are extensive, because the absorption can also result in secondary Cushing syndrome. And anthralin is an irritant that is also used for non-inflammatory type of thick psoriasis, where the scales are very thick, localized. You can use anthralin. The one of the most popular treatment, especially in the Western world, is vitamin D3 analogs, that is calcipotriol. So this calcipotriol ointment is applied. It is quite good along with steroids. Also, we can use it. So steroids will reduce the inflammation, whereas vitamin D3 analogs will reduce the scaling and reduces the proliferation of the keratinocytes. Salicylic acid helps in removing the scales, and it has to be given with caution when there is severe erythema. Tazorotene is a vitamin A analog. It is a retinoid, so that can be used. And most important is when the full body involvement is there, it is better to apply oil like liquid paraffin or other emollients, petroleum jelly. Even it just Vaseline is all that is required for localized lesions. Phototherapy is also recommended. We have got PUA and narrowband UVB. Nowadays, we prefer narrowband UVB with 311 nanometer wavelength, and it reduces the proliferation of the skin. Then topical corticosteroids, as I have told, limited application, and when the lesions are localized, you can use. Try to use mid-potent steroids. Don't use clobetasol and halopetasol for a long time. They will have systemic absorption, so it can result even in atrophy and stria and tachyphylaxis. Tachyphylaxis means there will be tolerance. Okay. Then systemic therapy, methotrexate, one of the oldest drugs that was being used in the management of psoriasis, weekly dose of around 7.5 to up to 20-25 milligram you can give. And even sometimes it helps to reduce the arthritis also. Retinoids, mainly acitretin. Acitretin can be considered as the drug of choice for pustular psoriasis. As I have told in the picture, now there is a newer drug called as pesolimab, which is a biologic, but otherwise acitretin is good both for psoriasis as well as for psoriatic arthritis. And cyclosporin acts as a crisis buster. If the lesions are red and it is expanding in other parts of the body, give a course of cyclosporin rapidly. It reduces the inflammation. We can give up to 1.5 to 150 to 200 milligram of cyclosporin, and gradually you reduce. Then acitretin, I was already told. Apremilast is a phosphodiesterase E4 inhibitor. The main problem with apremilast is that all patients do not respond, and there is an element of gastritis as the side effect, vomiting, diarrhea. So if it occurs, so you start with a very low dose, even 5 milligram, 10 milligram, then you gradually increase apremilast. The standard dose is 30 milligram twice daily, but most of the patients do not tolerate that dose. So many a times we just give 30 milligram. Azathioprine is one among the drugs that is being tried, but is not the drug of choice. Same with mycophenolate mofetil, hydroxyurea. Topical and systemic tacrolimus, which are immunosuppressive, has also been tried. Then colchicine, especially for pustular psoriasis, may be effective. Vitamin D3, that is calcitriol, may also be tried. So coming to the latest, that is biologics. So biologics for the last 20 years considered as the mainstay in the treatment of psoriasis. In fact, in Western world, they are mainly dependent on the newer biologics like ixekizumab, secukinumab, ustekinumab, tridalkizumab, guselkumab. So all these things. The MAB means monoclonal antibody because these are all prepared through genetic engineering techniques, so they are quite costly. Initially, we had a drug called as etanercept, partially effective. It acts on TNF alpha. This etanercept, adalimumab, infliximab. So it is effective in psoriasis, psoriatic arthritis, and ustekinumab. It is interleukin 12 and 23 inhibitor. So it is quite effective in the management of psoriasis. So you give 45 milligrams subcutaneously week 04 and then once in 3 months. So many patients feel good with this drug. Ixekizumab, now it is available in India. Only thing is that the cost, it is not possible to afford for everybody. Insurance coverage is also not uniform. So 160 milligram initially, that is 2 injections you have to give. Then 80 milligram every 2 weeks till 3 months, and then you give once a month. We conducted phase 4 trial for the ixekizumab. It is quite effective, but the moment you stop, it comes back. Same with secukinumab also. Secukinumab is available for the last 10 years now. Previously, Novartis was marketing. Now it is being marketed by Cipla. So once again, 300 milligrams subcutaneously, 0, 1, 2, 3, 4, and then every month. It is quite good, not just for psoriasis, but also for psoriatic arthritis. Interleukin 23 inhibitors, these are not freely available in India, and this can be used both in psoriasis as well as psoriatic arthritis. As far as India is concerned, we have infliximab, adalimumab, etanercept, ustekinumab, ixekizumab, and secukinumab. Guselkumab is probably being marketed next year or so. But the main hindrance in giving biologics is that the cost and the insurance coverage is not there most of the time. But some of them do get insurance. Depends probably on the premium and the type of insurance policy that they have. So this is one of the patients who received ixekizumab. There was almost near cure, but once again it comes back once we stop the treatment. Thank you very much. So I have basically talked about the clinical features of psoriasis, the topical therapy, systemic therapy, and recent advances in the management of psoriasis. Thank you very much. Thank you all. If there are any questions, I am happy to answer.
Thank you so much, sir, for taking out your valuable time and sharing your knowledge on this topic, sir. I definitely think this session knowledge will help all the participants during their practice also. Sir, I can see, sir, we have received some questions, sir. If you allow, with all your permission, shall we take these questions?
Yeah, yeah. Why not? Yes.
Yeah, thank you so much, sir. And I can see one question from Dr. Nabanita Poddar, and she's asking, are there any specific skincare product or routine you recommend for psoriasis, sir?
Actually, psoriasis, the basic problem is scaling of the skin. So we advise them to apply emollients. Emollients means the oil or commercially available petroleum products. So these are helpful. Even a simple coconut oil is also can be applied in the management of psoriasis routinely. Okay, so they need not take any topical corticosteroid creams or other creams. So we can give just what are called as emollients. Emollients means the one which actually hydrates the skin.
Thank you so much, sir, for answering this question. Moving forward, sir, I can see one another question, sir, like from Dr. Subramaniam. He is asking, how do tropical treatment work, and are any side effects? What's your point of view on that?
You see, side effects are there with most of the medicines. When you are using topical corticosteroids cream, you have to see whether the patient really requires it or not. For localized lesions, yes, we can give medium strength corticosteroid creams. The problem with the potent steroids is that it can get systemically absorbed. And also the topical side effects. The topical side effects of psoriasis are atrophy of the skin. There may be folliculitis, acneiform eruptions, hypopigmentation, telangiectasia, striations, and other increased hair growth, that is hirsutism. So, seven rainbow side effects of topical steroids. So, sometimes the moment we stop, there may be exacerbation. So, what we do is when we are giving topical steroids, we also ask them to combine it with emollients so that the amount of corticosteroids that is required to reduce the intensity of the disease is less. Then drugs like calcipotriol sometimes can produce irritation. Tezoretine also can produce irritation. All these requires a very supervised care, not like just ordinary emollients. Then when we use the coal tar shampoo, that also can result in irritation. If there is any secondary infection, that has to be treated. So all these points we have to consider before we institute topical treatment.
Thank you so much, sir, for answering it really well. I hope that Dr. Subramaniam has received his answer, sir. Moving forward, we will be taking one last question for today's session, sir. This question is from Dr. Ankita. She's asking, sir, what are the benefits and risk of light therapy for psoriasis, sir? What's your point of view on that, sir?
Yes. You see, the benefits currently we have got two types of light therapy. One is you give sorolins orally, and then after 2 hours they are exposed to UVA sun, UVA light. Many a times these facilities may not be available everywhere. Only in the medical colleges, district centers, these will be available. So we sometimes advise them to expose themselves to the sunlight, but when they are doing like this, they will have to wear a protective glass, otherwise there will be damage to the eyes. And afterwards there should not be excessive exposure to sunlight. So that is very important when we use PUA, or when it is sunlight we call it as PUA sol. The narrowband UVB, they have to just stand in the phototherapy chamber. We are not going to give any drugs. The problem here is that they have to come weekly thrice, or at least twice a week. So many of them are coming from distant places, and many of them will have to, you see, they have to do their job. So all these are hindrances. Then, when the disease is quite active, phototherapy can increase the redness of the skin also. So this is also a possibility. But the benefits actually outweigh the risks, and narrowband UV along with emollients is quite useful in the management of phototherapy. But nowadays, with the advent of biologics, most of them actually now don't give phototherapy. Previously, we used to give even with methotrexate. Along with that, we used to give phototherapy. We used to call it as MIPUA. Okay, so methotrexate plus phototherapy was also being advocated. Nowadays, phototherapy we do give, but only when the patients can come regularly for the hospital visits, and when they do not have a very severe active disease.
Thank you so much, sir, for explaining it very beautifully, sir, and very impactful, sir. I hope that Dr. Ankita has received his answer, sir. And I would like to, like, I can see there is no more question. I hope you have done justice to this session and you're able to clarify all the doubts related to this topic through the presentation, sir. And it was really nice, sir. Like, you took your important time to have this talk show, and I am very honored to have you, sir. And thank you so much, sir. Like, as there is no more questions, sir, with all your permission, shall we conclude this session?
Yes, thank you. Thank you very much.
And
So I
thank you
thank
so much,
all the
sir.
listeners also. Yeah.
Yeah, sir. And thank you so much, sir, once again. And we would like to see you in future also. Till then, take care of yourself, sir, and happy Diwali in advance. And to all audience also, may this Diwali bring lots of happiness and lights in everyone's life, sir, and healthy life, sir. Thank you so much. Take care, sir.
Thank you. Thank you.
Bye, sir.